Hi, Shashi and Pratik. Welcome.
Thank you, sir.
Hi, can you, your audio, everything you checked out, your slides also?
Yes, sir. The panel has checked.
Wonderful.
Yes, sir.
So, Pratik, welcome, Pratik. Thank you.
Welcome, sir. Thank you.
So, should we wait another 5 minutes?
I think maybe 5 minutes and just one more should come. Thanks.
Yeah.
No difference. There is no difference. That is what. All these happening here also, so it is able to implement. That is the reason. This is the purpose of the how implantation occurs. Why it occurs in the tube?
So that are the
These are not
delegates joining in?
Yes, sir, they are. It will take a minute more. And Vinay, do we start? A very good evening and a warm welcome to all of you present here. We welcome you to this very engaging webinar with a very esteemed and an experienced panel. My name is Siddharth Bhardwaj and I'm the Senior Product Manager with Fisher & Paykel Healthcare. It gives me immense pleasure and honor to introduce and welcome to you a clinician who actually needs no introduction, Dr. Karthik Nagesh. Dr. Nagesh is the chairman and HOD of neonatology at the Manipal Hospitals. He is also the chairman of Manipal Advanced Children's Center and an adjunct professor in pediatrics at Manipal University. With more than 3.5 decades of experience in neonatology and neonatal critical care, Dr. Nagesh received his MBBS and an advanced degree in pediatrics and moved to the UK to pursue neonatology and neonatal intensive care. He has been instrumental in conducting statewide newborn health initiatives with the WHO and the NNF. Dr. Nagesh gets repute for being one of the very first to use air transport for sick neonates and the first pediatrician to use surfactant in children's. He's been conferred the FRC PCH from London for his immense contribution to neonatology. Amongst the many accolades that Dr. Nagesh has, he is also one of the advisors to the World Health Organization. We are immensely grateful for you to spare your time, sir, and would like to invite you to lead this very educational webinar. Over to you, Dr. Sir.
Thank you so much, Siddharth and Monica and the rest of my colleagues and friend colleagues at the Fisher & Paykel company. Thank you so much for having invited me and my colleagues to this very interesting panel discussion. discussion, which is probably the most contemporary of topics in the realms of neonatology as of just today. It's indeed my proud privilege and pleasure to introduce my colleagues who will be probably joining me shortly. I'll just share my slides first, please. Is my screen available to be seen, Siddharth?
Yes, doctor.
Okay, I just see, we are in a situation today where prematurity is increasing rapidly. From an incidence of about 13% in this country, the recent National Family Health Statistics has suggested that we are probably going up to almost 15% in this country. As we all know, India still contributes to the largest number of preterm babies in this world. Close to about 1 million babies in India are born preterm, and that's the largest by any means in any country. So when we look at prematurity as a major cause of death, we realize that probably the most important amongst the causes of death in premature babies is respiratory problems. So that is why this symposium seems to be very, very important as of just today. It's my proud privilege and pleasure to welcome Dr. Sridhar Vishwanath, who's an esteemed colleague in the city of Bangalore. Dr. Sridhar has a great reputation as a very dedicated neonatologist in Bangalore as of today. He has had his initial training in the medical college in Bangalore at the KIMS Hospital. Subsequent to that, he was doing research at All India Institute of Medical Sciences and then moved to the UK for further training in pediatrics. He subsequently worked in various hospitals in the UK and spent about 6-7 years before he got his MRCP-CH and subsequently his certified clinical training from the General Medical Council after working at Yorkshire and the Pediatric Humber Training Scheme. He's done his DCH also from the University of Leeds and was awarded FRCP-CH in 2017. Subsequent to that, he was a consultant and subsequently a lead for neonatology in Rotherham in NHS Trust in the UK. Came back to India in the month of October 2019 and since then has been working as lead neonatologist at the Sparsh Hospital in Yeshwanthpur. But now recently, with the change in the profile of the Sparsh Hospital, which is now concentrating on women and children, I think it's a very appropriate decision. He has been now made the lead for women and child neonatology at the Sparsh Hospital in Bangalore. So it's with a proud privilege I'm welcoming Dr. Sashidhar. Another very young and dynamic and very, very sensible neonatologist is Dr. Prateek, who has got so many accolades to his credit. He is a MD and DM in neonatology from the Lady Hardinge Medical College in New Delhi. He is currently the Associate Professor of Neonatology at the Indira Gandhi Institute of Child Health, government institution in this city of Bangalore, which has become a very, very important lead referral center for critically ill sick babies in this part of the country. He's a dynamic person. He is a very, very aggressive researcher and trainee. He enjoys training students. He's had about 36 publications peer-reviewed to his credit as of today. So we are looking forward to a very interesting session today. Just to introduce the topic, neonatal respiratory care became an important subject of concern when President Kennedy's child, born then at 34 weeks of gestation, was taken to Boston because of developing severe respiratory distress syndrome in the early 1960s. Before then, about 5 years before then, Professor Mary Avery from Philadelphia had suggested that the reason for respiratory distress in premature babies is the deficiency of this substance called surfactant, which doesn't allow these babies to breathe well after birth. When this baby subsequently was treated in Boston, in spite of the best care given, the president's child himself, the child unfortunately died. that set about a chain of reaction where a lot of funding was given into neonatal research for respiratory care for babies, and ventilating newborns was probably the best thing which could have happened at that time in the 60s. Even as early as 1967, the CPAP was a kind of modality of treatment at that time propagated for respiratory distress syndrome. What really took another great leap forward in the field of neonatal respiratory care was the introduction of surfactant, which was confirmed to be effective in the early 80s by Fujiwara from Japan. And subsequent to that, all of us have seen this last about 30 years or so, 30, 40 years, neonatology has grown by leaps and bounds. So such situations where in the early 90s, some of us have been very fortunate to have seen the growth of neonatal respiratory care in this country as well, where we would ventilate babies with such severe respiratory distress syndrome. You can see the white out of the lung the babies are born with, and we would have old-fashioned ventilators giving a lot of pressure-limited ventilation. And the babies, in spite of this, would of course survive, but probably not appropriately so. They would have what's called chronic lung disease and oxygen dependency and lengthy periods of stay in the neonatal ICU. So this ventilation, of course, was a kind of modality which many units in this country in the mid-90s started doing. But at that time, we would not know that what we are doing was probably harming these babies. And in the late 90s, we realized that what we are ventilating small babies with using high pressures was probably leading to lung injury in these babies, providing a situation of what's called chronic lung disease. So towards the end of the late 90s, we realized there's something called bronchopulmonary dysplasia, which is a fallout of ventilation. It was well described by people like Professor Alan Jobe, and suggested that there is a alveolar arrest in growth, as a result of which also there is associated vascular abnormal development and abnormal pulmonary function, which was leading to chronic lung disease in these babies, which was more detrimental to the babies. The pathogenesis of lung disease in prematures was well in a kind of, it became quite clear that the very act of initiating the work of air breathing in a baby who was not able to breathe well at the time of birth, and subsequently doing aggressive mechanical ventilation and providing a lot of oxygen associated with the possibilities of sepsis or chorioamnionitis, all this was causing severe lung injury and damage to these babies. So that when we would ventilate such babies with pressure limited ventilation, the ventilation itself could have been probably more harmful than the disease. This became very clear to us, most of us. And therefore, over the last couple of decades, from being aggressive ventilation, we have now moved on to babies to try to do as much as possible with non-invasive support so that that aggressive lung injury doesn't happen to these babies. And so much so, in today's world, if you look at the present state of high-resource neonatal ICUs in the private sector or in the public sector in this country, of which close to about 800 of them are there, and private sector about 600 neonatal units are there in the country, our results in extremely small babies, even gestations less than 26 weeks, as in this baby here, suggest that our results are quite comparable in terms of survival. And we are not doing any way lesser than many of the Western countries. So with this background, I just wanted to share what would be probably the best appropriate practices to be done in the first golden hour of respiratory care, as we call it. Subsequent to this, once I finish, I would have the pleasure of introducing Dr. Shashidhar Vishwanath, who's going to talk about more non-invasive ways of achieving good respiratory care in premature babies. And of course, if you still need to ventilate babies, which is quite likely, in about 30% of the times, you may still need to ventilate babies, that would be taken up by Dr. Prateek, who's going to talk about the newer modalities of ventilation which produce less lung injury to the baby. So I'll probably start with my presentation first and just give a little overview of what it takes to minimize lung injury and do appropriate respiratory care in the first golden hour. I think more and more of us are now realizing that the first golden hour is very appropriately named, because in that period of time, the premature baby who's so born has a high risk of death. And even if you were not to look at mortality, the morbidity which can be accrued on the baby because of whatever we do at the time of that, or whatever act of omission which we do at that time, can lead to subsequent significant neurological impairment of the babies and multiple other issues with the baby. So, of course, we are going to today concentrate on the respiratory problems which happen to a premature baby at the time of birth. As I mentioned earlier, nearly 10 to 15% of babies are born prematurely, and many of them would be no doubt late preterms or moderately preterms, but at least about another 10% of those premature babies will be extremely premature. So we are looking at scenarios where aggressive care is required at the time of birth so that these babies are safely managed. So the golden hour strategy is just a philosophical concept. More and more of us are realizing that evidence-based protocols and procedures need to be standardized and put as a package in these babies in most units so that good resuscitation is done. There's a dynamic situation happening at that time. A lot of complex decisions need to be taken, and a lot of communication between the team members is required. So to put it in a nutshell, the problems in premature babies mostly related to respiratory care are that the surfactant deficiency causes severe hypoxia, hypercarbia, and possible acidosis in these babies, which need to be circumvented at the time of birth. Because they have a weak chest muscles and inadequate effects on ventilation, they become more chances to develop hypoxia. And at the same time, while we're treating the hypoxia, we want to be very sure they don't get hypercarbic as well. So these are all the things which you need to plan at the time. So even before the planning of a preterm delivery, lot of simulation, lot of training needs to be done amongst the team members to try to achieve this. Most important, of course, we all know that hypothermia needs to be prevented in premature babies, but particularly related to the respiratory care, the key elements today, which we keep on thinking about, is after you've stabilized the airway and the cardiopulmonary support is being provided, you have to make sure you don't get into a mode of aggressive ventilation. So the child needs to be gently ventilated or given respiratory support at the time of birth, and while you are transporting to the neonatal ICU, and optimal respiratory supports, which need to maintain good oxygenation and prevent hypercarbia in these babies, need to be discussed, which is what we're going to discuss in the next few minutes. The care of the premature baby's lungs starts even antenatal. So it's our duty as neonatologists and pediatricians who look after babies with prematurity, we have to go by what are the guidelines available. I think the last, almost since 1994, enough evidence is there that antenatal steroids would definitely improve the lung maturity, and it accelerates fetal lung maturity. And now enough meta-analysis says that it also reduces the risk of perinatal death in babies and the risk of intracranial hemorrhages, apart from mitigating the effects of RDS in babies. Whether we use betamethasone or dexamethasone, and we advise the obstetricians either to give 2 milligrams of betamethasone, 12 milligrams of betamethasone, 2 such doses 24 hours apart, or 4 doses of dexamethasone 12 hours apart, it's the same. Probably both of them work the same, though the government of India and many state governments have suggested the use of dexamethasone and the NHM dexamethasone. But in high resource situations, betamethasone is ubiquitously being done. And I'm very proud to say that in cities like Bangalore, the NMR has reduced significantly by just act of intervention. And the incidence of RDS significantly has come down to almost 60% if you give antenatal steroids. Even in situations where the mother has infections, severe chorioamnionitis, tuberculosis, or it is multiple pregnancies, or the mother has severe diabetes, it can all be used safely with cautious monitoring of the mother. Extended periviable ages, gestations 22 to 24 weeks of gestation also in many countries, including ours, if the parents and the family know the possible consequences of an extremely periviable baby and they're willing for that, antenatal steroids can be extended backwards towards 23 weeks of gestation also. We know that as soon as the baby is born, cord clamping, if it is delayed, can have its ubiquitous advantages, though primarily to the respiratory system, it may not. But then if the child is hemodynamically more stable, cord clamping is a benefit, it's a boon. So we should always try to see if this can be initiated with good dialogue with the obstetrician and the other perinatal team. The recommendations is what we follow is many recommendations, but at least 30 to 60 seconds is what the NRP suggests. So if the baby is active and crying, even if it's a premature baby at the time of birth, you can probably delay the cord clamping to even minimum 30 to 60 minutes if you can do that, unless the child needs active resuscitation. Temperature management is very important, keeping the delivery room warm, keeping the baby well covered in a poly wrap. These are all protocols which are part of the neonatal resuscitation protocols for premature babies, which we all know. But it's very well recognized, and meta-analysis now suggests that if there's a low admission temperature in preterms, that increases even the respiratory morbidity and the risk of mortality. This was published even 20 years back by the CRIB score and the SNAP score, which suggested that hypothermia is a leading cause of morbidity and mortality in the NICU. So we need to make sure the baby is kept warm. So I'm just emphasizing that respiratory care is not necessarily only related to the use of interventions like CPAP or intubation, but you have to take care of these things. The most important thing, last about 10 to 12 years we have been doing, and this is what I really need even at the periphery doctors to understand, is that hyperoxia can bring its attendant complications on the baby. We need to make sure that babies are given oxygen and air blended. We cannot in today's world think of giving 100% oxygen to babies, even in the resuscitation areas like the labor room or the operating rooms. And guidelines say, even European guidelines recently have been updated, which suggest that if you're going to deal with a baby who's less than 28 weeks of gestation, you start with 0.3%, 0.3 FiO2, and then based on the oxygen saturation, which you would have to do, you'd have to place a pulse oximeter on the right wrist or the hand of the baby and take the preductal oxygen saturations. Target oxygen saturations have to be looked onto. And if there is a need, you increase the FiO2, or if there is no need for the oxygen, you bring it down to 21%. Gestations above 28 weeks, you would even start even at 21%. So that is very, very important. We all realized, and this we realized about 20 years back, as I mentioned, that if you use hard ventilation in the baby, right from the baby is born, the word go, the child comes out hypoxic because the child has got some surfactant deficiency and the child is hypoxic. On top of it, you would induce lung injury. If you look at this, kind of cartoon of the molecule of the kind of micro photograph of the alveolus, you will see that the minute you start instituting high pressure ventilation to this baby, there's a rupture of the alveolar lining, which is getting flood fluid, which is the interstitial fluid. And as a result of which, frequently, the child's surfactant production doesn't happen, and the child has a high chance of getting chronic lung disease. So this is a sensitization which we are telling most neonatal pediatricians, that right at the time of birth, you have to be very careful and be very gentle with the baby. Subsequently, of course, Dr. Prateek and Dr. Shashidhar will be talking about, if you were to ventilate these babies, either in the delivery room or subsequently, you would need to remember that the pressure volume curve like this in respiratory distress, if you see, you should not overventilate the baby, neither should you underventilate. So you should always keep a PEEP and keep what is called an inflection pressure going, and don't overventilate the baby. So the green kind of curve here, which is the middle portion of this pressure ventilation loop, that is where you need to ventilate babies on. So this is something which a sensitization is required. And about 15 years back, the COIN trial, which has really clearly shown that once you have a baby delivered with respiratory distress, early CPAP works. And you just apply a good CPAP with a nose or covering the nose and the mask, it is able to obviate the reason for ventilating these babies by almost 50%. You don't need to ventilate these babies nearly 50% of the times if you start early CPAP. So look at this. If the mother has been given antenatal steroids, she delivers in an appropriate place, even in utero transport, if she has been brought to at least a level 2 or a level 3 setup, and you start early CPAP in this baby, you don't need to ventilate these babies ever. This is what is happening most of the time, which we are seeing it in high resource situations like this. Prophylactic CPAP, which the support trial has suggested right now, which I mentioned earlier, was the early rescue CPAP. But on the contrary, if you were to have a baby gestations of just less than 26 weeks, you start prophylactic CPAP. That also obviates the need for giving surfactant and intubating in close to 40% of the times. So that is so good that you just need to have one modality, the CPAP. CPAP has to be applied well, and delivery room CPAP is what is the in thing now. Preferably, you should use what's called a T-piece device. I'll come to that later. Basically, these T-piece devices, as you can see, it is able to deliver a fixed, correct, whatever you set. It is not as if it will go above the set pressure which you have suggested. So no doubt it can deliver the set pressure of CPAP, or the PEEP, as you have said. It can also help you deliver blended air and oxygen mixture to the baby. You can have a pulse oximeter with a probe on the right hand or the wrist of the baby, delivering the appropriate targeted oxygen saturation. And as you can see here, the CPAP well applied on a nose and mouth of the baby is able to deliver good respiratory support to the baby so that oxygenation can improve. The T-piece device, as I discussed earlier, is what is the appropriate thing to be used. The advantage is, apart from regulating the higher, it's got a pop-off wall. You can, of course, use it once in a while, as the finger here shows. If the baby doesn't have a good respiratory drive, apart from giving CPAP, you can keep putting a finger pressure on that wall there so that it can generate PIP also, which can also be regulated in this baby. For example, you can set the PIP as 18 and maybe a PEEP of 5, and that can deliver the appropriate PIP and PEEP to the baby. So this becomes part of the armamentarium for use in the delivery room for a premature baby. We don't use the ambu bag at all, and neither the self-inflating bag which the anesthetist suggests we should not be using for a premature baby. The other thing is sustained inflation. That means you would keep the baby with a positive high pressure of, let's say, 20 or 25 centimeters of water for about 25 to 30 seconds. That's dangerous. I've shown this slide just to show that in the delivery room, we should not attempt this. There was a fashion in the mid-2000 last decade, the mid-last decade, to use what's called sustained inflation. But meta-analysis towards the end of last decade has suggested that if you were to continuously press and give a high PIP to the baby for 25 to 30 seconds, the baby may have a high risk of death and increased chance of air leak syndrome. So this slide is just to show that this should not be done. Heating and humidification of gases has definitely found to be beneficial. It reduces heat loss in preterm babies, and data suggests that even the admission hypothermia reduces. So if you have a blender connected to a heated humidified circuit and then connected to the CPAP device, that works even in the delivery room. But many times this is not able to be achieved easily, even in high resource situations. But nevertheless, always enough evidence that humidification helps. So these are all the principles which I wanted to delineate: delayed cord clamping, thermal care, delivery room CPAP, T-piece resuscitator, use a blender to titrate the oxygen, use a heated humidified circuit, avoid sustained inflation. So the next part of my talk is going to tell a little bit about what needs to be done soon as the baby is delivered and subsequently you are caring for in the transition area itself, or you're trying to bring the baby back to the neonatal ICU. Early use of caffeine. 2007 itself, this data has suggested that it reduces the incidence of chronic lung disease in very low birth weight babies. Caffeine is good. It's safe, inexpensive now in this country. IV and oral preparations both are available. And data suggested that if you use caffeine and then use it till 34 weeks of gestation, 11 years down the line also, it reduces neonatal morbidity in terms of neurodevelopment being better. And the cognitive skills of children, including the motor skills, are better. So caffeine is a wonderful drug. We should probably keep that high priority in our list of things to be used for premature babies. Surfactant, of course, this was a drug tried out in 50,000 babies in 40 clinical trials in the late 1980s before it became a standard of care. There's a one universal drug which has been shown to improve infant mortality rate and neonatal mortality rates. The only thing is, there is no use giving prophylactic surfactant. As has been shown by the COIN trial, even if you use early delivery room CPAP, you can use the surfactant subsequently if the baby develops respiratory distress. So you don't need to waste surfactant necessarily, if especially in today's era where antenatal steroids have been given and you initiated CPAP early, probably surfactant you can wait and see, unless the child develops severe respiratory distress and needs oxygen of more than 30 to 40%. As I mentioned, the European guidelines have now suggested that in gestations where the baby is less than 28 weeks of gestation, if the FiO2 is more than 30% on CPAP, which is being delivered at 6 centimeters of water, surfactant is necessary to be given. Gestations of about 28 weeks, you can wait even till 40% of FiO2 is reached. The exception is only if the baby is very apneic and has severe respiratory distress at the time of birth, where you need to intubate the baby, then of course you can give surfactant even in the delivery room. Otherwise, you can give it as early as within 2 hours after birth in the NICU. Porcine surfactant, there's no doubt, meta-analysis has suggested it reduces the incidence of BPD, and the dose in porcine surfactant 200 mg per kilo is better than 100 mg per kilo or 100 mg per kilo of Beractin surfactant. The method of surfactant delivery has become more and more non-invasive. There was a time in the late part of the decade of 2000 and early part of the last decade, we were all doing insure, that is intubate, give surfactant and extubate within 2 hours or so. But now most of us in this last 2-3 years are trying to adapt ourselves to lesser invasive surfactant administration by using a catheter to institute the surfactant into the lungs of the babies directly under laryngoscopic vision, with the child not being removed from nasal CPAP or non-invasive ventilation. And this works better in terms of reducing the incidence of chronic lung disease. So another great strategy to avoid lung injury to the baby. It's probably better than using insure. So other people are trying, and in fact, some of us are also trying to develop a protocol to do aerosolization of surfactant, and probably this may become the thing of the future, where the child is going to be just given non-invasive ventilation with respiratory distress, and you're just aerosolizing surfactant with a nebulizer. Of course, LISA still remains the kind of most important way of giving non-invasive surfactant right now, with a period of brief tracheal catheterization. Oxygen targets have become very clear because of the multiple trials on oxygen, the neoprom trials, and it's very clear that you need to maintain an oxygen target to prevent BPD and ROP and other problems due to oxidant injury. So the targets are to be between 90 to 94%, either about 5 to 10 minutes after the baby has been stabilized. This should be the target. So this should be the target in the NICU, and suggestions like 99 and all that should be absolutely avoidable. So the alarm limits in most monitors should be set at 89 to 95%. A lot of data is available on this now. So if you look at the progress in neonatal respiratory therapies over the last 4 to 5 decades, this last 20 years has suggested that more and more of us are moving to non-invasive forms of respiratory care like CPAP, high-flow nasal cannula, and less invasive surfactant therapy. Sustained inflation is out. We are talking about probable future use of nebulized surfactant as well. Ventilators are lying unused in most of our neonatal units because the paradigm has shifted to the change in the motto saying less is more. You just do lesser invasive care and more the benefits for the baby. Postnatal interventions after you stabilize the baby in the labor room is, as I said, early caffeine, non-invasive support, surfactant, in case of ventilation to use a lung protective strategy, which my colleagues are going to talk about, and maintain target saturation between 91 to 95%. So if at all you need to still ventilate babies, this is what Dr. Prateek is going to talk about. You would use lung protective ventilation and open lung ventilation strategies and other forms of volume ventilation. So just to summarize, if a resident or a neonatal pediatrician is called for and your fellow has to attend a delivery, which is a gestation who are less than 28 weeks, especially antenatal steroids, magnesium sulfate also improves the neuroprotection in the baby. So antenatally, you should inquire whether it's been given. Check whether there is fever the mother or any evidence of chorioamnionitis, and if there's any suggestion of antepartum hemorrhage, because there the baby will require active resuscitation at the time of birth. Team allocation is required, performance equipment check, all these the NRP protocols are required, keeping the room warm, arranging a polywear wrap and a transport incubator. Obstetricians can be requested to probably do delayed cord clamping if the baby comes out vigorous, and gentling handling. And of course, delivery room stabilization. In the event the baby is actively crying, keep the baby warm. In the poly wrap, you can use a T-piece at the time of delivery. High flow nasal cannula is not good for primary mode. It is okay later after the baby has been stabilized and subsequently you want to extubate the baby or remove the baby from CPAP. There's also evidence that sustained inflammation is not, again and again, I'm emphasizing that. Gentle positive pressure ventilation with the T-piece device is the way to go with a heated humidified circuit in case the baby's respiratory distress is significant or there is apnea in the baby at the time of birth. Delay the cord clamping as much as possible. Even 60 seconds is okay if the baby is active and crying. And even if you want to start oxygen, start maybe with 30% and go back to 21% if it's not required, monitoring the oxygen saturation. And of course, once the baby is brought to the NICU, you can decide whether early surfactant needs to be given. The resuscitation protocol doesn't indicate the use of ambu bag at all. We should desist from using an ambu bag. Oxygen targets are available. All these protocols are available in the new ILCOR guidelines published last year in October. And typically, if the baby has been stabilized and the baby is in the transition, you would watch for respiratory distress. You would continue the oxygen mask. You would have a pulse oximeter there. You'll keep the baby under a warmer care. You have an oxygen and blender monitoring the child, and clinical respiratory distress you would monitor with the hold of with some kind of a scoring system. You would need to intubate the baby in the delivery room only if there is persistent respiratory distress in spite of maximal CPAP support of 7 centimeters, or if the oxygen requirements are increasing to more than 30%, or there is persistent or prolonged apnea. So once the child is stable, you need to now bring the baby to the nursery or the NICU or transport the baby to another NICU elsewhere. Now, there is where the problem lies, and that is a solution we have found, that you need to continue using the CPAP. Here is where cannulas like the RAM cannula have helped up. Instead of a mask, we usually switch to a RAM cannula with preferably a blender. That was the best thing if you can have a blender going on with a transport incubator, which can provide good PEEP to the baby, can transport the baby in a warm environment in an incubator and with a close monitoring of the cardiorespiratory and the saturations. Of course, the targets to be achieved on CPAP is to improve the clinical condition. The respiratory distress should have come down. There should be a decrease in oxygen requirement. And the blood gas, if you have instantaneous blood gases available, that's fantastic, which I'll come to later. But blood gas should have a pH of more than 7.3 at least, and the carbon dioxide permissible is 40 to 60. And of course, once the baby comes to the NICU, you can monitor the respiratory distress using any scoring systems you want, and then decide whether the child needs surfactant, especially if the FiO2 increases to more than 30%, you can use surfactant by Lisa technique. This is a note of caution, a slide which is very important to show that even in late preterm babies, please don't think that the baby may or may not need NICU care. Our own data, which we published 5 years back, has suggested that in these gestations, nearly 25% of the times, the baby needs respiratory support and needs NICU care. Okay, if the baby is stable initially and the baby just needs a little bit of observation for 2-3 hours, that's fine. But if the baby needs more and more oxygen and needs CPAP care, the baby then sometimes needs to be attended to in the NICU. Even if it is not respiratory distress syndrome, it may be just transient tachypnea of the newborn, but the baby needs some care. The X-rays can determine whether it's respiratory distress syndrome like the severe RDS here, or it's transient tachypnea of the newborn like this mild amount of fluid in the interlobar fissure here. And that can tell you, even in these babies, which is the way to go ahead. Of course, babies with pneumonia and meconium may need longer stay in the NICU. The other point of care assessments at the time of NICU care, just when the baby has been brought in the first 1 hour, as soon as the baby cares, the blood gas is the gold standard. But then if you don't get a blood gas from the preductal area, you can go for a good arterialized capillary blood gas with warming up of the heel. Now, point of care devices like the iStat are able to give us a decent reading of the pH and carbon dioxide. And oxygenation, of course, you have a non-invasive method of calculating the oxygen saturation index. Our own data suggests that the OSI is linearly correlating well with the oxygenation index between levels of 5 to 18. So this also can become a good non-invasive modality of monitoring the baby in the neonatal ICU in the first couple of hours before you are able to put in arterial lines and get proper arterial blood gases for assessing the oxygenation and carbon dioxide of the baby. Point of care ultrasounds are now available, both in terms of looking at the heart, to look at the cardiac function functionally, and also the lung to determine how bad the lungs are. Surfactant, as I discussed earlier, porcine is better and it should be ideally administered soon as possible within the first 2 hours after the baby. Most of us, we now are pre-medicating babies with caffeine, avoiding sedation as much as possible. And under direct vision, most of our fellows are able to give surfactant to the less invasive surfactant administration technique while the child is still breathing and the child is still on CPAP support. LISA is being performed in many, many units, and this is done well. And the children are coming out very well. So if you were to summarize the plan of RDS management, this is a flow chart which suggests that if the baby is spontaneously breathing, try to maintain on CPAP most of the time and go ahead and give LISA surfactant. Only the FiO2 increases to more than 30%. If you were to look at babies, 90% of the times you'll get away by doing this non-invasive assessment, unless the baby is apneic or has severe respiratory distress requiring more than 50-60% oxygen at the time of birth. You hardly need to ventilate babies or intubate babies. Even in late preterms, babies may sometimes need respiratory care, as I mentioned earlier. So you have to be a little careful and closely monitor them, and we can't really let them go away soon after attending to at the time of delivery. They need to be closely monitored. The stabilization in the neonatal ICU mostly depends on optimal respiratory support and, of course, other cares like temperature control, antibiotics, fluids, and nutrition, which all of us as neonatologists are very well aware. The National Neonatology Forum has given clear guidelines to the CPG, or what we call the clinical practice guidelines, of which we were also fortunate to be part of the exercise in the writing group. CPAP and non-invasive support is the way to go for babies. And this should be probably our motto for the next few years to come. And babies, no doubt, need a lot of effort on top part of the theme, which probably is very important to be sensitized. And a lot of us are aware it's the nursing care also which is able to do well for our babies. And we are really very fortunate for our nurses to be so well trained in the field of neonatology and to be able to help our babies survive better all these years, and are very, very dedicated and hardworking residents. So with this, I must thank for the opportunity to speak. So we'll take up the question and answers later. And I just was thinking whether we should go on with the next session. Thank you. Siddharth, can we go on?
Yes, Doctor, we can move ahead. We would now like to invite Dr. Shashidhar for his presentation.
Shashidhar has been with us in Bangalore for the last 3 years or so, almost 2 years. So Shashidhar is going to talk about the various modalities of non-invasive ventilation. Thank you, Shashi.
After an amazing presentation, I think Dr. Nagesh has made my kind of presentation easier because he's presented so much in terms of what needs to be done. So I have divided my presentation as to kind of classify actually what are we classification, what is the classification of respiratory support, what is non-invasive ventilation, and also some pertinent questions such as is NIV same as CPAP with rate, and then comparison between the high flow nasal cannula versus CPAP. And finally, we'll conclude few other points on it.
Can you just go to slideshow, please?
Oh, sorry.
Yeah.
Is it better now? Thanks. So I haven't included the high frequency nasal oscillation for a reason, but I'll talk about it in a minute. So very simple classification of respiratory support and ventilation is non-invasive and invasive. Anything without, well, I come to this. I mean, we all have some questions about this. Traditionally, anything without an ET tube was classified as non-invasive, and something which is given via endotracheal tube was classified as invasive, though we all have some reservations about it. So non-invasive includes nasal CPAP traditionally, and then the high flow heated humidified nasal cannula high flow therapy, and then also the non-invasive positive pressure ventilation, synchronized NIPPV, and also nasal high flow, high frequency ventilation. Now, invasive ventilation is the traditionally invasive positive pressure ventilation. Various modes of it is there, of which Dr. Pratik will talk a lot about. And also, fortunately, we haven't been trained, or we haven't seen much of the ET CPAP, which apparently was used, previously. So, just a little bit about the different types of injuries that can happen during the respiratory support that we provide. Dr. Karthik has already summarized it, but I thought I'll include one slide about this. So there is something, there's a term called ventilator-associated lung injury, and we all are aware of the various problems associated with ventilation, and also some of the non-invasive modes of supporting the breathing can also have some of these traumas. So volute trauma, barotrauma, atelectotrauma, and biotrauma. I mean, obviously the volute trauma is the trauma associated with hyperinflation of the volume, causing hyperinflation caused by the excessive volumes and the associated trauma. I think the slides Dr. Karthik Nagesh had shown has already talked about it. The pressure associated trauma, barotrauma, and the uneven kind of inflation of the different parts of the lung, leading on to various problems, VQ mismatch, that is called as atelectotrauma. And the biotrauma is the trauma associated with increased inflammatory mediators and associated with long-term and short-term problems with inflammation. And that is one of the things. The final outcome of all this is bronchopulmonary dysplasia, parenchymal lung disease. So, I mean, in general, the protective strategies, again, this is more for the invasive ventilation, but the protective strategies is to reduce the tidal volume and also permissive hypercapnia. Now, CPAP has been used for more than 30-40 years now, and I just summarize a little bit about CPAP because this is something which we still follow in most of the level 2 units and some of the bigger units as well. So CPAP is basically augmenting the natural breathing, and it's a physiological control when there is a tidal breathing. So it does go with the Herring-Brewer reflex, and there is the important thing is the negative pressure is the driving force in the provision of CPAP, and that is very important because most of the lung injuries happen when positive pressure is the driving force. So there is partial inflation and a reduction in the complete collapse of alveoli. That's the way it works, and it reduces the atelectasis. And also we know that it also helps apnea of prematurity. And in terms of the mechanism of action, it only helps the lung, helps to improve the position of the lung on the compliance curve, and it reduces the work of breathing both in preterms and also in term ones who need it. From a mechanical point of view, it does mimic the action of surfactant, very basically reducing improving the compliance, improving the elasticity and all that. So I'll just go to non-invasive ventilation. So what is exactly non-invasive ventilation? So any kind of ventilatory mode wherein we are not kind of invasively putting a tube. This is what the traditional definition was. So basically it was provision of positive pressure ventilation using a nasal prong or a mask with a circuit which looked like CPAP, and the ventilatory settings which were like the traditional endotracheal tube associated positive pressure ventilation, with some changes such as keeping the rate lower than the invasive ventilation around 20 to 25, whereas traditionally in the invasive ventilation we do use slightly higher rates. And the PIP is something which could be a bit of variable, because sometimes it can be quite high because of the associated leak with the baby opening the mouth or other circulatory reasons. Typical settings is around 18/5 with a rate of 25. The traditional NIPPV is not synchronized, but there's also something called synchronized ventilation. Sorry, I'll just go back. Just 1 second. We all know that any sort of ventilation wherein we are giving flow or pressure, we need to look after the stomach inflation. So we need OG tube, and the nursing care in the non-invasive positive pressure ventilation is similar to the CPAP care. They need to keep an eye on the observations, as well as making sure that mouth of the baby is not open, and other things that are used. So when do we use non-invasive positive pressure ventilation? Well, there are some studies in literature. I've tried to summarize it quickly. So for RDS as such, there are few studies, and basically when it was studied to see whether as a primary support in RDS, whether it is better than the traditional CPAP, the main outcome of interest was prevention of invasive ventilation. That is, allowing the child to be ventilated non-invasively. Both the results were that both CPAP as well as NIPPV reduced the need for invasive ventilation. Now, though on the outside it does look like it's a good result, but if you really look at it, NIPPV itself is a positive pressure ventilation, and from physiology we know that the inflation, the positive pressure inflation of the alveoli and the associated tear and the inflammatory response associated with it is the cause for long-term development of BPD. So NIPPV itself is a positive pressure. And if the baby can be managed on nasal CPAP, why do we really need to give positive pressure ventilation? So that was one of the things. And also, NIPP was studied for apnea also, wherein it was compared with nasal CPAP for prevention of apnea of prematurity. Now, there was some good results. Basically, it said that in those who had frequent and severe apnea, a non-invasive positive pressure ventilation was slightly better than the just nasal CPAP. So what about using NIPPV to prevent for extubation failure? Basically, so you've extubated and somebody is having apneas, what do we do? So this study looked at it, and basically for the outcome of prevention of reintubation, the results show that reintubation was less in the NIPPV group. But the concern again is that NIPPV itself is again, the previous slide which showed NIPPV itself is a positive pressure driven ventilation. Whether using ET tube or not using ET tube, there will definitely still be some trauma associated with positive pressure ventilation for the lungs. So then there was again some studies which compared the synchronized NIPPV. Synchronized NIPPV is the one wherein this the machine is built to synchronize the delivery of breath with the baby's normal breathing. And the studies show the results were slightly better in the synchronized NIPPV in reducing desaturations and bradycardias. There was another study in by Dumpa, Katz et al. In the 2012, which was published in Journal of Perinatology, with an objective to look at the overall clinical outcomes in preterm infants using synchronized versus the non-synchronized or the traditional NIPPV. So the overall outcome, that is prevention of long-term development of BPD, and also the short-term, use of failure of non-invasive ventilation, going on to invasive ventilation. All this, it basically showed there was not much of a difference, or in fact, no difference in the overall clinical outcome in this. So I was saying that some of the journals, some of the studies, as well as some of the results of meta-analysis and all that include CPAP and HFNC, the heated humidified nasal cannula, under the heading of non-invasive. Should you really use that is the question, because any form of respiratory support without ET tube is included as non-invasive. But that's not really right, I think, because ET tube or no ET tube, there is still the positive pressure related damage to the lungs. And many times the ET tube has been blamed for the adverse outcome, foregoing the effect of positive pressure ventilation. And I think there was some study which finally had shown that nasal NIPPV is not just CPAP with rate, but actually it is similar to invasive positive pressure ventilation without a tube. And this was very important to know, because that changes the practice. And nowadays, most units that I had worked in the UK as well, in the mid 2005 to 2010, they were using what is called on the machines, these CPAP with breaths, we used to say, in a colloquial term. And it's now very clearly shown that it's not useful. So we just use either flat CPAP or the other modes of ventilation that are required. So NIPPV should be compared with CPAP. Well, the respiratory mechanics are completely different. The NIPPV works more like pressure delivery, positive pressure delivery without the tube directly. Basically, you are foregoing the first part of the ET tube, wherein rather than delivering the pressure from the top, in the ET tube, it goes into the trachea. From there, it delivers. Still, all the bad effects, all the kind of adverse reactions to the positive pressure is still there. And added to that, problems with CPAP itself, the tummy distension, increased incidence of, though in literature it does say there is increased incidence of gastric perforation, other things, still, we need to be aware of that. There are various, I thought I'll just include this in the slide, but again, I personally not use this much. There are various ways to know when should we escalate care from CPAP or non-invasive to a CPAP to either a higher degree of care or ventilation. And we use increased incidence of apneas or increased FiO2s more than 40 to 50%, and in general the baby tiring. But there is an index which was used for a while called SOP index, which is a number you derive by multiplying the PEEP delivered with FiO2 in decimals divided by the SpO2 in decimals. So if the SOPI is more than 1.6, it's a indicator to increase the support. Yeah, so either to a higher degree of non-invasive or to invasive methods. So that is one way of delivering non-invasive ventilation, non-invasive respiratory support. So in the last 15 years, or 10 to 15 years at least, there has been a lot of, I would call it, initially it was called as a revolution, but certainly it's become now more of an adjunct in the field of neonatology, the heated humidified nasal high flow therapy. And this was used in adults more than, well before they were using in neonates. And it had shown good results. Now, what is high flow nasal cannula? So the full form, the heated humidified nasal cannula high flow, is self-explanatory. So we heat the air to normal body temperature of 37, at least 34 to 37, and we humidify to 100% ideally, 95 to 100% in most devices. And we deliver it through a nasal cannula which is soft, and it's small, thin, tapered tubes, binasal tubes, and which can deliver oxygen or oxygen and air mix at rates more than, or rather flow rates more than 2 liters per minute. Traditionally around we start like anywhere by 6 to 8 liters. And the important thing is it depends on the leak in the nostrils. So we need a loose fitting tube, and I'll come to that in the next slide. And as I have told, we heat to 37 degree and humidify to 100%. Now, how does it work? I'll come to the next slide, but basically it does generate CPAP, but there's no way of measuring it, and it is variable, and the pressure can be anywhere from 1 centimeter to 8 to 9 centimeter of water as well. And it cannot be measured and depends on various factors. The various factors could be the size of the prong that we are using, the size of the baby, whether the mouth is open or not, and also the flow rate. All of these will determine how much pressure, how much CPAP is generated. The physiological action, how does it work? Physiologically, how does it work? So because we are providing a flow, it washes out the nasopharyngeal dead space. And as we all know, 60 to 70% of the resistance, the inspirators as resistance is from the upper airways, the nasopharynx, the upper part of the trachea, and the bronchi. Only about 20 to 30%, or even less than that, is in the lower airways, the alveoli, the terminal bronchioles, and all that. So with high flow, it reduces the inspiratory resistance significantly associated with this, and that helps. The most important, or rather one of the ways that it really works is by when we provide humidified gas, it improves the lung compliance and lung compliance and the air conductance compared to dry and cold gas. So it's like if we are in a desert, versus if you are in a very humid place, the effort of breathing is different. So that's the analogy we can give. And because the air is already heated, the work needed to conditioning means to heat it and also provide the humidification. There is much less metabolic work associated with the heated humidified high flow nasal cannula therapy compared to the other non-humidified ways. And finally, high flow through the nasopharynx does provide CPAP. As we said, we cannot just measure it. So I have not included different brands and have not put pictures for obvious reason, but there are 3 ways of delivering. There are OptiFlow, Vapotherm, and also the standard nasal cannula high flow, which is non-heated, and the dry gas. And most importantly, the different devices, they all work in a similar way. The standard nasal cannula, the flow rate is anywhere from 1 to 4. It's not humidified and not warmed. We don't use it often at all, at least not in the centers that we are used to. Vapotherm and OptiFlow, again, they use humidification 95 to 100%, temperature of 34 to 37%, and the flow rates in neonates typically is 6 to 8 liters, and we very rarely, or in fact, the advice is not to exceed 8 liters per minute, or only in very, very rare cases we do. So after covering the physiology and how do we do it, there are certain do's and don'ts of nasal high flow therapy. The most important thing is we should not completely cover the nasal orifice with the tube. So the prongs should be covering around 50%, definitely not more than 80%. And that's very important because there should be a leak. Whereas in CPAP, leak is a problem. In heated humidified high flow therapy, leak is required for effective functioning of the high flow. And baby should not close the mouth while HFNC is being given. This is actually the case in neonates anyway. Most neonates don't close their mouth and they keep it open. And we still need a orogastric tube in situ for decompressing the stomach. And monitoring is definitely required as per the protocol, and certainly is very important when we are increasing the flow rate. And as I've again reiterating, flow rate of 8 liters per minute is something that has been shown as the maximum effective flow rate, not beyond that. So again, if the FiO2 is persistently more than 40%, we should shift back to CPAP or any other non-invasive methods, or in fact, invasive methods if there is no improvement. There are interfaces, company-specific interfaces. I included a picture of RAMS cannula because RAMS cannula can also deliver the flow, and it is in fact quite useful in transport, as Dr. Karthik Nagesh has already told. So what are the pros and cons of high flow nasal cannula high flow therapy? So the most important thing is it's very simple to use, and there is reduced work of breathing. The patient compliance is much better. There is no problem of baby opening the mouth, and it's quite comfortable, particularly because we don't cover the nostrils fully, and nursing staff also find it much easier to manage a child on high flow therapy. And even kangaroo mother care and other kangaroo mother care can be provided with nasal cannula high flow, and most of the procedures can be done without any problem while the child is on nasal cannula high flow. And the cons of it, disadvantages of it is mainly the variable PEEP and the risk of hyperinflation and gastric distension. The gastric distension is something that is preventable by putting a orogastric tube and keeping it under constant removing the air constantly. And there is theoretically increased possibility of lung overinflation. So I think when we are reaching high flows more than 6 or 7, we need to keep an eye on the inflation. And certainly, if you are using it for a long time, you need to look at the chest inflation either by chest X-ray or by clinical examination. So when do we need to use high flow? So as a primary, it's something that is shown to be useful only about 28 weeks, certainly. The indications are post-extubation, more than 28 weeks gestation. Stable infants were on CPAP, but it should not be used as a weaning modality per se. And certainly in children who have babies who have nasal injury, high flow is something, high flow can sometimes be very useful. Now, weaning off after CPAP, some centers recommend nasal high flow. But what we have found is once you get stuck on the once we start the high flow, there is some reluctance in clinicians to wean it off, certainly in the smaller centers. I'll come to that in the next slides. How do we initiate and how do we wean it? So as I said, we initiate at a flow rate of 6 to 8 liters per minute. And we always make sure the temperature is 37 degrees, at least 35 to 37 degrees, FiO2 30 to 40%, 100% humidity. Weaning is very important. I still remember the practice where babies were started on high flow, but for some reason they were just let on it for days to sometimes even more than a week. So once the baby is stable, once the FiO2 is 21 to 25% for more than 24 hours, I think we should actively start weaning half a liter to 1 liter every 6 to 8 hours. This is easily said and done because many times they just get comfortable and it doesn't happen. But more importantly, when you have to wean somebody from high flow, you start after the rate, after the FiO2 has come down to air, and you slowly come down actively in steps of half to 1 liter. Hopefully by 2 to 3 days, we should be off nasal high flow, and you can change to either additional low flow or sometimes just allow the baby to breathe in air. And the important thing is not to wean the humidity and not to wean the temperature. They need to be kept the same. Some of the slides I'm going to talk about comparisons between HFNC versus CPAP. Now, as a primary mode in more than 28 weeks, there have been 4 RCTs, and there was no difference in the primary outcome. Primary outcome is failure, respiratory failure. And there's some improvement in secondary outcome, that is the duration of respiratory, in fact, other way around, I'm sorry. There was increase in the duration of respiratory support in those who were initiated onto high flow directly. And again, I was talking about it because we do get comfortable, and nursing staff get used to this particular way of respiratory support. And many times they're not actively weaned off. Secondary mode, that is after you've tried a different primary mode. So if you see, there are 6 RCTs and then 934 infants were used. And the primary outcome as well as secondary outcome. Secondary outcome is the other effects. Primary outcome is the respiratory failure. There was not much difference. But in respect to the nasal trauma in the high flow group, there was a 36% less risk of nasal trauma. Again, it's because we use a softer, smaller, and more more easy to use tube. So that was useful. Summary, I kept it open because we have talked about, going on from the previous slide, we have talked about the delivery room methods to reduce the lung trauma, followed by use of gentle ventilation, followed by caffeine. And if you have to use, you use the CPAP, you use the high flow, then think about nasal NIPPV. But as in more and more, people are getting away from the NIPPV. And there's another mode called nasal high frequency oscillation, which I haven't included. If people want to discuss it, it's a complete separate discussion on its own. We can open up during the discussion. I think I have kept the time, and any questions we can answer it later. And again, I really thank Dr. Karthik for giving me an opportunity to present in such a esteemed group, as well as helping me and helping all the juniors. And I have to thank him again, because I've seen right from, Dr. Karthik might not remember, I had approached him in 2000 as a volunteer for a IAP, and he was the same, enthusiastic, helpful. And thank you, sir, again. And over to Prateek for the next.
Thank you, Shashi. It was such a wonderful presentation. Lots of questions, but I will refer to them later after Dr. Prateek's presentation. Prateek is a brilliant young neonatologist in the city of Bangalore, and he's really very academically inclined. So over to you, Prateek. Thank you, Shashi, and we'll have questions at the end of it. Prateek, can you start your presentation?
Yes, sir. Yes, sir. I'm starting. I hope it's visible to everyone.
Yes, it is. It is, Prateek. Yeah.
Good evening, everyone. I'm going to briefly discuss about the volume targeted ventilation in units. Slides are not.
Prateek, you can put your video also on if you can.
Yes, sir.
Slides, you can just use the scroll on the screen itself. Click it, it will go. If you can just see the arrow on your PowerPoint itself, just click it, it will work.
Is it seen, sir, now?
Yes, we can see it. Yeah.
Yeah. Good evening, everyone. I'm going to briefly discuss about the volume targeted ventilation in units. The outline of my presentation includes introduction to volume targeted ventilation, a brief mention about the ventilator-induced lung injury, the principles of tidal volume targeted ventilation, initiation of volume targeted ventilation and troubleshooting, and also the current evidence. Yeah, just a brief recap of different types of lung injury. My slides are not moving.
Sir, use your mouse. Use your mouse.
Just use your mouse and click the arrow on the screen.
Okay, got it, sir.
So yeah, that one. Just click. Yeah.
Coming to the brief recap of different types of lung injury. We know there are these are the various causes of lung injury. That is, either it is because of excessive inspiratory pressure, that is what we call as barotrauma, or excessive inspiratory tidal volume, what we call volutrauma, or it may be because of lung injury, maybe because of excessive closing and opening up of alveoli, that is recruitment and de-recruitment, what we call atelectotrauma, and or it may be because of excessive airway flow, what we call rheotrauma, or it may be because of inflammation and infection within the lung, and this is called as biotrauma. Among all these different types of lung injury, it is the volutrauma, that is excessive stretching of the lung due to excessive tidal volume, which is the important factor in the ventilator-induced lung injury. So this is one of the very old experiments which was conducted by Dreyfus et al. In 1988, which most of you will be familiar with. He ventilated rodents with 3 different modes. The first mode in the red color graph, what you can see is the high pressure and high volume mode. And the second mode in the yellow color is the low pressure and high volume. And in the blue one, you are seeing the high pressure and low tidal volume. Here, low tidal volume was achieved by strapping the chest and abdomen of these rodents. And low negative pressure in the yellow color graph, which you're seeing, was achieved by generating a negative extrathoracic pressure. And in these rodents, the markers of lung injury, like the dry lung weight of the lung and the amount of albumin which was extravasated into the extravascular space, was seen. So what they saw was, irrespective of the pressure delivered, it was the tidal volume which was the important determinant of lung injury. You can see here in the blue graphs, irrespective of very high pressure, when the abdomen and chest was strapped, the low tidal volume caused very less lung injury. So based on these experiments and many other clinical experiments, it was seen that this is the same photograph of the same experiment. You can see here excessive tidal volume has caused serious lung injury in the third specimen. So based on these experiments and also the many clinical studies, it was determined that the volutrauma is the most important and critical determinant of lung injury. So since volutrauma or the tidal volume is the critical determinant of lung injury, clinicians came up with the idea of what you call as volume controlled ventilation. That is controlling the tidal volume during the ventilation. So in volume controlled ventilation, the clinician sets the delivered tidal volume. That is, the volume is the control variable or the fixed variable. Here the pressure varies up and down to deliver that target tidal volume, and ventilator will cycle from inspiration to expiration once the tidal volume is delivered. Let us see the difference between the commonly used pressure limited or pressure controlled ventilation and volume controlled ventilation. In pressure controlled ventilation, it is the pressure which is prefixed. That is, pressure is fixed, and the volume delivered into the patient's lung depends on the compliance of the lung. If the compliance of the lung is very poor, then the volume of tidal volume delivered will be less. If the compliance is good, the tidal volume delivered will be more. In volume controlled ventilation, as I told, the control variable is volume. That is, the pressure changes to deliver this tidal volume. You can see here, if the lung is too stiff, that is, if the compliance is less, then more amount of pressure is required to deliver the same fixed tidal volume. So in pressure limited, pressure is constant. In volume limited or volume controlled modes, the tidal volume delivered is constant. But in volume controlled ventilation, what is controlled is the amount of volume which is injected into the ventilator circuit. It is not the tidal volume which enters the patient's lung. Here you can see the patient's lung is only a part of the circuit system. What is controlled in volume controlled ventilation is the amount of volume which is delivered from this ventilator, and it is not the amount of volume which enters the patient lung. The amount of tidal volume, the amount of volume which is delivered from the ventilator depends on so many factors like compliance of the tubing, and also the compressible volume of the circuit, and also the humidifier, and also the leak around the endotracheal tube. So whatever volume or tidal volume which has been delivered at the ventilator end may not be exactly reaching the patient end. So this was one of the fallacies or problem with volume controlled ventilation. So to overcome this problem, clinicians came up with what we call as volume targeted ventilation. Basically this volume targeted ventilation is actually a modification of pressure controlled ventilation. The common pressure controlled ventilation which we use are SIMB, assist control, and also the PSV mode. Here in volume targeted ventilation, there is a delivery of targeted tidal volume, which is set by the clinician based on the microprocessor adjustment of the inflation pressure. Let us see the steps of volume guarantee. Here, initially, the first step is to choose the target tidal volume. Once you choose the target tidal volume, you have to choose the pressure limit or the PIP limit to which the inspiratory pressure can increase or decrease to deliver that tidal volume. So first step is to choose the tidal volume based on the patient's disease condition and also the gestation age. And next step is to choose the pressure limit. Here you're not going to choose the peak inspiratory pressure, but you're going to choose a limit within which the ventilator will try to give the targeted tidal volume. Then the microprocessor, what it does is it compares the tidal volume of the previous breath and adjust the pressure. Either it will increase or decrease to deliver the same targeted tidal volume. Let us better understand with this graph. Here you can see in the test breath 1, the ventilator will deliver a certain amount of pressure, that is peak inspiratory pressure, and it notices the amount of tidal volume. In the breath number 2, since the tidal volume target is not reached, the ventilator increases the pressure and again tries to achieve the target tidal volume. Here the targeted tidal volume is almost achieved. But in the breath number 3, again you can see because of decrease in the patient compliance, the tidal volume target is not reached. Again, ventilator, what it does is it increases the peak inspiratory pressure so as to deliver the target tidal volume. And again, in the 5th breath, the same amount of pressure is delivered as compared to the breath number 4. That is, but if there is any improvement in the patient compliance, again there is a overshoot of tidal volume. So in the breath number 6, you can see here, ventilator again decreases the pressure to deliver the fixed targeted tidal volume. So basically here the pressure is changing or fluctuating to deliver the targeted or whatever the tidal volume the clinician has been set. You can see here in this graph, here the first graph is the flow and second one is the pressure and third one is the tidal volume. Here with volume guarantee, there is lot of fluctuation in the pressure delivery, but the amount of tidal volume delivered when the volume guarantee is on is almost constant. Whereas when you switch off the volume guarantee or the targeted tidal volume, this thing, all the pressure delivered is almost constant, but you can see there is so much variation in the tidal volume delivery to the patient. So coming to the initiation of volume guarantee, the first step in initiation of volume guarantees, you have to choose a basic mode, basic pressure control mode, like a assist control or SIPPV, what we call, or a pressure support ventilation. Then next step is to select the backup rate. Backup rate should be usually around 10 breaths less than the physiological rate of the baby. For example, if the baby is a term baby, you can set around 30 to 35. If it's a preterm baby, you can set the backup rate of 40 breaths per minute. Here, backup rate, the purpose of backup rate is by chance if the baby goes into apnea, this rate at this rate will be delivered. Next step is to select the peak expiratory pressure, peak end expiratory pressure, which is appropriate to the infant's diagnosis and the clinical condition, and also to set the FiO2. And most important thing in initiation of volume guarantees, that is tidal volume targeted ventilation, is you have to ensure that the flow sensor is calibrated and it's properly functioning. Without a proper flow sensor, you can't give the volume guarantee. So once you've done all this, next step is to select the targeted tidal volume target. So tidal volume target depends on the disease condition. If the baby is a term baby, late preterm, or a baby who's having a normal lung, then you have to set a minimal tidal volume of around 4 ml per kg or 4 to 4.5 ml per kg. If it's a preterm RDS baby, again 4 to 4.5 ml per kg is sufficient. If it's a baby with RDS, around 4.5 to 5 ml per kg can be set. And if it's a preterm baby with less than 700 gram with severe RDS, then higher tidal volume should be set because of increased instrumental dead space in such babies. In preterm baby who is having evolving BPD and if it's like a 3-week-old baby who needs ventilation, then higher tidal volume needs to be set because of increased alveolar dead space in these babies. In a term baby with meconium aspiration syndrome who has a classic chest X-ray of infiltrates all around the lung with hyperinflation, you have to again keep a higher tidal volume because of increased alveolar dead space. In a meconium aspiration syndrome with whiteout X-ray, the classical whiteout X-ray, but without any hyperinflation, you can again keep a lower tidal volume of 4.5 to 5 ml per kg. In a CDH baby, again, 4 to 4.5 ml per kg is sufficient. In a baby who's having established severe BPD, that is an old BPD, which we call, higher tidal volume should be kept because of increased alveolar dead space and also because of increased anatomical dead space. So tidal volume, whatever we set initially, again depends on the disease condition. The peak inspiratory pressure also have been mentioned here. Again, it has to be set based on the disease condition of the baby. Once the targeted tidal volume has been set, the next step is to set the peak inspiratory pressure. Here, the clinician is not setting the peak inspiratory pressure, but he's setting the limit within which the peak inspiratory pressure is delivered. So peak inspiratory pressure limit should be usually 3 to 5 centimeter above the expected peep for that baby. For example, if the expected peep or the what you call the peep which is required for the baby is around 16 centimeter of water, then you can set a what you call PIP limit of around 19 to 20 centimeter of water. If more PP is required than anticipated, then you have to make sure that the endotracheal tube is not blocked or kinked, or it should not be malpositioned in the right bronchus. Then subsequent adjustments of the in the patient is based mainly on the clinical assessment of chest rise, breath sounds, and saturation. Most important thing in when you're connected the when you're continuing volume guarantee ventilation, the baby should be breathing comfortably. If the baby is not breathing comfortably, if there is severe retractions or if there is increased work of breathing with tachypnea, that means probably the tidal volume which is being delivered is inadequate. So in such situations, you have to look for what is the reason for inadequate delivery of tidal volume and have to increase the tidal volume once you have ruled out all the other causes like obstruction or malpositioning of the ET. And one should always look around the leak around the endotracheal tube. That is also very important for in the subsequent adjustments. So always you have to present the working peak inspiratory pressure and also the PIP limit in the round so that the clinician knows what is the working PIP, and also the doctor who comes on duty on the next day will know the working PIP. So the tidal volume adjustment in the patient who is receiving volume guarantee is mainly based on the pH in the blood gas and not the PCO2. Only if the pH is alkalotic, that is if there is respiratory alkalosis, then you have to come down on the tidal volume. Otherwise, tidal volume is usually not touched when you're giving the volume guarantee. If the patient is alkalotic, as I told now, if there is a respiratory alkalosis, then you have to come down on the tidal volume of around 0.5 ml per kg. To calculate the tidal volume, initially one should use the birth weight, and if the baby has crossed the birth weight, and then present weight should be taken if there is a weight gain. One should not solely rely on blood gas. Also, one should assess the respiratory rate, comfort, oxygen requirement, and also the working pressure when you're giving the tidal volume targeted ventilation. And if the patient has increased work of breathing, then one should increase the tidal volume if the support is not adequate. One of the important concepts which I would like to highlight is regarding the transpulmonary pressure. It is the transpulmonary pressure which determines the total tidal volume which is delivered into the patient's lung. The transpulmonary pressure is actually the negative intrathoracic pressure which is generated by the patient by its own spontaneous effort, and also the positive pressure which is given by the ventilator. So one of the fallacies, one of the problem with volume guarantee ventilation is the variable tidal volumes. Let us see in this graph. You can see here when the patient in the first breath, here the tidal volume whatever is delivered is mainly based on the peak inspiratory pressure which is given by the ventilator, and also by the negative intrathoracic pressure generated by the baby. So there is target. So the tidal volume delivered is more than what is required for the baby. So in the second breath, what ventilator does is it decreases the amount of PIP which was given compared to the previous breath, and also the patient has taken a less spontaneous effort, but it is not high as the previous breath. So again, the tidal volume delivery is okay. If in the third breath, the ventilator will give the PIP of the previous breath, because the ventilator assumes that the patient has got an adequate tidal volume in the previous breath. In the third breath, the ventilator has given a peak inspiratory pressure which was delivered in the previous breath. But here the patient has not taken any spontaneous efforts. So there is drastic fall in the tidal volume. Again, if the baby takes since the tidal volume is reduced, what ventilator does is it increases the peak inspiratory pressure. But here the baby has taken a spontaneous breath, but there is overshoot of tidal volume. Again, since there is overshoot of tidal volume, ventilator gradually increases the peak inspiratory pressure to achieve the targeted tidal volume. So if any chance if the patient takes a spontaneous effort, then there will be overshoot of tidal volume. So this is one of the problem with in the ventilators which use targeted tidal volume, mainly because of varying inspiratory efforts in a preterm baby. Preterm baby may have a very good inspiratory effort in one breath and may not have a very good effort in a subsequent breath. So ventilator will take time to adjust for these variations, and it will take time to deliver this targeted tidal volume. But this problem has been overcome by the recent Draeger VN500 and Draeger Babylog 8000 ventilators, which has a separate algorithm for what you call the spontaneous breaths of the baby and non-spontaneous breaths. For the spontaneous breaths, you can see here the pressure delivered is same. For non-spontaneous breaths, that is only the ventilator delivered breath, the working pressure is different. So as this algorithm actually maintains the constant targeted tidal volume. Coming to the weaning in volume guarantee ventilation, weaning in volume guarantee ventilation is automatic and it happens in real time. As the patient's lung compliance improves, there is gradual decrease in the peak inspiratory pressure, which is required to deliver the tidal volume. So one should not decrease the tidal volume as the peak inspiratory pressure is reduced. So weaning is automatic and it happens in the real time. So you should not reduce the tidal volume, as I told, unless the patient is alkalotic. If the patient is having respiratory alkalosis, then you have to come down on the tidal volume by increments of 0.5 ml per kg. You have to increase the PEEP to maintain the adequate distending pressure as the PAP comes down. You should not use SIMV and do not wean the backup rate in pressure control and assist control or PSV. In SIMV, you should not use to give volume guarantee. The reason is that in SIMV, only the breaths which are triggered by the baby are volume guarantee. The untriggered inflations, the volume guarantee is not supported. Whereas in assist control and pressure support ventilation, every breath of the baby which is above the trigger level is supported. So hence, that is why we prefer assist control or pressure support ventilation when you give volume guarantee, not the SIMV. So coming to the extubation, you have to consider extubation as per the standard guidelines. That is, if the working pressure, whatever the patient is getting, is somewhere between 12 to 14 centimeter or 15 centimeter of water with satisfactory blood gas, then you can consider extubation in that patient. The readiness of extubation can be assessed by spontaneous breathing test if your unit is doing this. Otherwise, you can directly extubate the baby. Most important thing is caffeine should be used in a preterm babies less than 32 weeks to reduce the chances of extubation failures. And post-extubation respiratory support with either a NIPPV or CPAP should be given, again to reduce the chances of extubation failure. Coming to the troubleshooting in volume guarantee, sometimes when you are practicing volume guarantee ventilation, the only common thing which you encounter is low tidal volume alarm. It means the tidal volume is not reaching its target. The main reason is either because of decreased compliance, whatever may be the reason, or increased resistance, or if you kept a very short alarm delay, or if there is a very large endotracheal tube, and if there is a malfunction of flow sensor, or if there is intermittent exhalation episodes in between by the baby. And if the ventilator is not generating any peak inspiratory pressure, it means what you are set a very low tidal volume for the baby's physiological needs. So that needs to be checked, and you have to also look for the disconnection in the ventilator circuit. If there is tachypnea or increased work of breathing, then you have to look for the tidal volume which has been set. If it is very low, then you have to increase the set tidal volume. If there is a persistently low PCO2, then it can be because of the metabolic acidosis or severe agitation in the baby. You have to consider lowering the tidal volume only if the pH is low. Only PCO2 alone should not be taken into the account. Coming to the evidence with volume guarantee ventilation, this is the Cochrane systematic review of 2017, which showed that there is reduction in the combined outcome of death or bronchopulmonary dysplasia by almost 27%, reduction in the pneumothorax, reduction in the number of days of ventilation by 2.3 days, reduction in the hypocapnia, and also the combined outcome of periventricular leukomalacia and grade 3 or 4 IVH was also reduced with the use of volume guarantee ventilation. This is the same forest plot of the what I told just now. There is reduction in the death or BPD by almost 27 times. So one of the important drawback of volume guarantee ventilation is the presence of, not a drawback, it is a need. There should be a proper flow sensor at the patient end. If the flow sensor is not functioning, or if there is a malfunction of the flow sensor, then the ventilator will switch back to the PIP limit, whatever you are giving. But again, there is a safety feature in one of the newer Draeger ventilator where the ventilator will not go back to the what you call the PIP limit. Instead, it goes back to the working pressure, whatever the ventilator was giving previously. Other problem with volume guarantee ventilation is if there is a very large leak around the endotracheal tube, then the amount of tidal volume, expiratory tidal volume, which comes from the patient, the ventilator thinks that the tidal volume is delivered is very less. Hence, during inspiration, more amount of tidal volume will be delivered. So it results in inadvertent hyperventilation and hypocapnia. So these are the two problems with volume guarantee ventilation. And if you feel if there is a large endotracheal tube, then you have to replace the endotracheal tube, especially if the leak is more than 30%. This again is compensated with the newer ventilators like VN500, which has a leak compensation mechanism of up to 70 to 80%. In conclusion, it is the volume trauma, which is the critical determinant of ventilator-induced lung injury. Clinicians should usually come out of their comfort zone and they should start using the volume-targeted ventilation. I'm using the word volume guarantee because it is specific to a specific ventilator. And lung injury lies in the hands of a physician. So hence it's aptly called as physician-induced lung injury. When you initiate a volume guarantee in a new unit, a formal protocol is a very effective strategy to implement. Thank you.
That was wonderful, Pratik. I mean, really very, very nicely explained. You carried the point very well that volume cycle ventilation is probably the way to go ahead, even if you need to mechanically ventilate babies. So can I request Dr. Shashi there? Shashi, can you just come online, please, with your video on? There are many questions which have been brought to the chat box. But before the questions, which are very interesting, I just thought we can have a little discussion on a little bit. Can I start with you, Shashi, about this little bit clarity on oxytrauma? What is oxytrauma? You're muted, Shashi. You're just muted. Yeah.
Sorry, am I audible now?
Yes, yes.
Yeah. So I think the oxygen itself, Dr. Pratik Nagesh has already started on this presentation. So oxytrauma, which is basically, due to the excess use of oxygen. Oxygen is a drug, and it is a free radical induced injury, and sometimes excessive use of oxygen without proper targets. And very, very importantly, as you said, 89 to 95 being the target. So that itself causes a cascade of inflammatory reactions, and I think that possibly is one of the major reasons why oxygen has now been regulated as a drug, as well as particularly in the neonatal practice. I think that's what I understand, Dr. Nagesh.
Okay. Now, following that thing, now more and more of us are talking, or there's a concept of automated oxygen control in the neonatal unit. Can Pratik, can you throw some light on this? What is this automated control of FiO2?
Basically, preterm neonates are at increased risk of both hypoxic episodes and hyperoxic episodes. Hypoxic episodes are also common in a growing preterm, and also because of that, clinicians usually try to increase the FiO2 limit, and because of this, hyperoxic episodes are also more common. So in automated control of oxygen delivery, usually there is an algorithm. If there is a increase in the FiO2 concentration, the algorithm tries to reduce the amount of FiO2 which is delivered to the baby in a stepwise manner, so as to maintain the oxygen in the targeted SpO2 range. So this is what is called as the targeted oxygen oxygen targeting. There is no much clinical evidence, I mean, with respect to the reduction in the BPD or survival as such, but there are only few studies which have looked at whether the patient sustains in that saturation zone or not. So compared to the manual adjustment in the oxygen, when there is a machine-induced or algorithm-induced control of this what you call oxygen delivery, there is reduction in the number of hypoxic events and also the hyperoxic events.
Very nice. In fact, recently I had the occasion to listen to Professor Kevin Ives from Oxford, who's the original researcher on automated oxygen control using the high flow nasal cannula device. So there is a kind of microprocessor which controls the amount of oxygen based on the oxygen saturations. Even in his study, even with an automated control device, close to 20% of the times there is a hyperoxic or hypoxic episodes noted. So you can imagine if there is a manual adjustment of oxygen being done by nurse on sitting next to the bedside. So how important it is to monitor the oxygen closely. You can imagine how things can go wrong. So fantastic. So as long as we are sensitized and all of us neonatal pediatricians are aware that oxygen can do more damage than good, we have to be careful and probably regulate the use of oxygen. Neither, of course, letting the baby get into hypoxia. So are we all agreed upon an oxygen target of 91 to 95%? Would you say, Shashi, that's quite
Yeah,
okay?
that's correct,
Yeah.
sir. Thank you.
With a good pulse oximeter in the preductal area, that is the right hand of the child, that should be, I guess, okay. Now, Shashi, just one or two issues on your presentation. What would you call a CPAP failure in case you want to ventilate a child?
Um, so in terms of calling a CPAP failure is when you're delivering adequate CPAP, giving proper pressure, a proper FiO2, but there has been increase either in the amount of oxygen required, and we have to, and also the pressure, but associated with excessive apneas, and we are not able to get the target SpO2. So that would constitute CPAP failure. Now, regarding the oxygen, at what oxygen level would you consider it as CPAP failure? So traditionally, if you are above 40% in term babies, preterm babies, and about 30-35% in term babies, and you're making sure that the circuit is working fine and every other factor is taken care of, and is still not achieving the target of saturation, as well as the you're having more of desaturations and evidence of that in blood gas, then that would be caused as a CPAP failure. And we consider whether we have to increase the support or go for the invasive.
Okay, now Pratik, I just wanted to refer to this word called permissive hypercapnia with regard to, let's say, you're keeping a child on non-invasive ventilation. What do you define? How do you define it, and how much do you accept?
So permissive hypercapnia basically means you accept a higher level of PCO2 by giving reduced giving the what you call lower tidal volumes in a baby who is on mechanical ventilation. So most important factor which determines the what you call carbon dioxide level in a baby is the minute ventilation. Minute ventilation is the respiratory rate and tidal volume. It is the tidal volume in the baby which is the most important factor for CO2 in the baby. So in permissive hypercapnia, a clinician is permitting the PCO2 level at a higher range by giving less tidal volume to the baby, and at the same time there is a less lung injury. There is less volume trauma and less lung injury. So routinely one can accept usually you have to in the first week of life you can accept up to 45 to 55, and in the second after the first week of life you can accept up to 55 to 60 level of PCO2 provided pH is more than 7.25. If the pH is more than 7.25, then you can accept a higher level of PCO2. But if you go by evidence wise, the FELB trial did not show any benefit with respect to bronchopulmonary dysplasias with different levels of PCO2. So but still it is a good practice to achieve higher level of PCO2 so that you're not injuring the baby's lung by giving excessive tidal volumes. Another important thing is the increased carbon dioxide also helps in distribution of oxygen to the peripheral tissues and unloading of oxygen, what we call Bohr effect. So these are the benefits of permissive hypercapnia.
I may just add to what Shashi and you have said just now. Failure of CPAP, maybe I would be happier to even wait till 60% FiO2 and 6 centimeters of water with increasing respiratory distress clinically by any scoring system we have and deteriorating blood gases. So what I would do, probably this is something which some of the lessons from Amit Mukherjee's group in McMaster's we have heard, is they would go on to nasal high frequency oscillation in this, as Shashi mentioned earlier. Using the same interface, using a ventilator, you would go on to high frequency oscillatory ventilation, which we have tried. Anecdotally, we have tried in some children. And there we would go on to similar settings to a high frequency oscillation with maybe a small baby like this will keep the frequency about 12 or so. delta P just enough to raise, get a good wiggle in the lower chest of the baby, and FiO2 based on whatever the child was getting, and a mean airway pressure a little about 2 to 3 centimeters above what the child was getting on CPAP. We have tried it anecdotally, but I do not know if any of you has experience in using an HFOV nasally. Have
I
you tried
haven't,
that?
sir. I haven't used. Maybe
Pratik, you have tried that?
Yeah, we have used in few babies, sir, as a mainly as a not as a primary mode of respiratory support, mainly as a post-extubation respiratory support to prevent the extubation failures. Actually, it was given as one of the postgraduate thesis as a pilot study. But if you and it was only a pilot study where we just saw whether the safety and feasibility of nasal HFOV. We did not compare with NIPPV or any other modality, but it was safe and feasible with respect to the use as a post-extubation respiratory support.
So that's another thing. We would like to try that out rather than re-intubating and ventilating babies. But then definitely that we still need to study that.
It
now,
can be
Shashi,
before intubating the baby.
Yes,
if the NIV fails, you can use nasal HFOV as an additional step before going for elective intubation.
Yes. So most of these modern ventilators, like the ones you mentioned, they would have the ability to support that modality as well. So Shashi, I'm going to come back to you again. As far as high flow nasal cannula is concerned, there are multiple questions on this from our delegates here. They're asking in less than 28 weeks gestation, would you suggest using high flow nasal cannula as a primary modality?
No, sir. I think the research is there has been a good amount of research and a lot of papers on it. As a primary modality in less than 28 weekers, CPAP still scores if at all you want to use, but nasal cannula hasn't shown any good effect at all. So as a primary mode in less than 28 weekers, I would not use nasal cannula as a choice.
I definitely, the hipster style, which was just for, there was a question here, which is a reference they want to know. The hipster trial, which was published in 2016, clearly suggested that high flow nasal cannula is inferior to CPAP as far as primary mode is concerned in gestations of 28 weeks and less. We, of course, even 32 weekers and less, we would not go for high flow nasal cannula at all. We'd rather start with good CPAP and with a good interface like a mask. I would really prefer a mask. Do you have any suggestions? Either of you, do you prefer the mask or a nasal prong? Either of you can tell me.
Sir, I prefer the silicone masks. There was one of our juniors, I mean, when I came back from UK, I was still getting used to some of the things that she used to use Ram's cannula as a CPAP, it worked in some. And that we had to use for some reason of nasal trauma. We had a series of preterm babies where due to the older one, the plastic kind of a thing. And I still believe the gold standard of providing a CPAP is a mask CPAP. And if you have a nice soft silicone mask, which is properly measured, and that's where the problem is, I think, the nursing staff and doctors also, the proper measurements are not taken, and sometimes inadvertently smaller or a bigger one, wherein there is a lot of leak. So I still believe we should use mask. I mean, Pratik.
No, I would concur with you. In fact, last year, early in the year, one of the meta-analysis, which was actually published by one of my students, Dr. Abdul Razak, who was earlier in McMaster's, he had suggested to his meta-analysis of, I think, 8 to 10 trials that the mask is superior as compared to even prongs, and we would definitely prefer a mask, and the trauma definitely is less. But of course, sometimes there's a trauma to the root of the nose, unlike the prongs, which can cause a trauma to the columella here. So some units, of course, practice alternating the mask and the nasal cannula, but that's left to the ease of how the nurses feel in that unit. But I think mask is probably. Now, as far as the high flow nasal cannula is concerned, there is one question by one of our delegates here, which I'll just read out as it is verbatim. Dr. Shirish Bhatt says, please you share the reference articles for the slide on the use of HFNC in 28 weeks preterm? I mean, I don't remember the slide.
Yeah, but
Do you
this-
remember?
Sir, I didn't actually include that slide. I mean, if they want, I can send it to the required people and they can share that. Yeah.
Okay. The other thing is Dr. Muthukumar Rajagopalan has got a pertinent question, which I think any of you can answer. How would you ventilate when these preterms come back for some surgery in later days? This happens many times. We have got the child out and subsequently the child needs some surgery. Let's say for inguinal hernia, they come back or they come back for a surgical problem. What would you already done a great job of doing non-invasive ventilation? So what did you talk at this? What is your thought on this, both of you?
I'll let you
Yeah.
pick.
Yeah. So, Pratik, please tell us.
Usually, if the patient's lung condition is normal, I mean, if the baby did not had any STOMI clinical course, then these babies usually require very short duration of mechanical ventilation with a very minimal settings. But inguinal hernias usually commonly happens in the patients who are having bronchopulmonary dysplasias, usually BPD babies and preterm babies who had very prolonged respiratory effort. So in such babies, the problem is, so in such babies, they may require a slightly higher pressure, but most of these babies who require surgery, the duration of ventilation will be usually shorter. It will not be like for a prolonged period of time.
No, that is right. But if you have to definitely, let's say, ventilate for 2-3 hours and then subsequently, no doubt he'll get off the ventilation. What would you use as a modality? I'll tell you one reason. Recently, we had a child was referred to us from a place called Shimoga. And this baby had a ventriculoperitoneal shunt needed for a bad hydrocephalus. This child was not ventilated when they came to us. Subsequent to that, since the procedure was going to take about 2-3 hours for a good VP shunt, in fact, the anesthetist requested whether the ventilator, the SLE 6000 itself can be brought into the operating room. And we did volume cycled ventilation in that baby for the duration of the surgery and subsequent to that for some time. So would you think that's appropriate or is there any other? Because most of the times in the operating room with the Boyle's apparatus and the ventilation, which the anesthetists do, they usually hand ventilate for a short procedure, or sometimes they connect to the Boyle's apparatus and the ventilator, which doesn't deliver volume cycle ventilation. So probably Dr. Muthukumar wants to know this. So this is the solution we had in our unit because we didn't want to ventilate the child aggressively. So do you think that's a good thing to do?
Yes, sir.
Maybe. I mean, I couldn't think of anything better than that because we shifted our own ventilator into the operating room and did it because we didn't want to hurt the baby's lungs any more than what it was necessary. So this is one thing we just can suggest, Dr. Muthukumar. The other question, Dr. Shirish Bhatt is again asking, how does using only SIMV without volume guarantee cause reduction in respiratory distress? No, sorry. How does using only SIMV without volume cause distress to neonates? Please justify the evidence.
How does using only SIMV without volume?
Without volume.
I didn't understood the question, sir.
See,
Normally, when you use SIMV with volume guarantee, the number of breaths which are, for example, if you are using SIMV with volume guarantee, only the set number of breaths which is set by the clinicians will be supported. If the patient is taking more number of breaths compared to the clinicians, whatever the clinician has said, those breaths will not be supported. So, so in SIMV, when you use SIMV with volume guarantee, you may have to give slightly higher tidal volume compared to SIMV plus VG, SIPPV plus VG to maintain the minute ventilation. So when you are using SIMV plus VG, you have to give a higher, you have to probably set a higher tidal volume target so as to maintain the what you call the minute ventilation.
But your point is well taken. That is because SIMV doesn't support all the breaths of the baby.
When you use SIMV, when you use SIMV, it is a dictum that it should be used with pressure support because so as to support the untriggered inflations. So SIMV, when you are using, it should be always used with PS. SIMV as an individual modality should never be used. Even the recent Goldsmith says that.
Okay. Now, Dr. Bhatt, he's asking, are we not considering permissive hypercapnia to be harmful nowadays with recent long-term studies?
Yeah, long-term studies show that there is no much improvement with respect to the what you call with respect to the permissive hypercapnia. But if you see with respect to the lung injury, definitely you are giving less tidal volumes.
Okay. Now, one question to Shashi. You mentioned about SI and synchronized NIPPV. So it's earlier days we used to have a Grace capsule connected to a ventilator, which would detect the abdominal breaths and then give a positive respiratory support to a NIV baby. But we don't get those kind of ventilators anymore. Is there any particular ventilator you're aware which can do SNIPPV?
I actually haven't used this mode of ventilation during my training, but it had to be added on when I was presenting it, because I remember we had these some of the machines which were kind of just giving breaths with some pressures, top pressure, bottom pressure we used to call, and that's actually not an effective way of providing the so-called non-invasive positive pressure ventilation. And then in where I was working, it was basically stopped, and we said flat CPAP in a well baby or in unwell baby as well, just continue. So my experience with using or any particular ventilator which has it is not, we haven't used much in there.
No, I just wanted to answer that question also myself, because there is, in fact, I have done a lot of reading on this, and myself, we use a lot of NIPPV using standard ventilators. So when I looked around, there's only one ventilator in the whole world right now available from Italy. It's called the Julia ventilator, which can do SNIPPV. No other ventilator. So though most of the data has been published saying that SNIPPV is better than simple NIPPV, most of the meta-analysis suggests, because most of the original data has been done on the ventilators which had the Grace capsule.
Okay.
So now the other thing is, of course, NAVA, which is the one where you look at the diaphragmatic signals, and then, but then of course it's still not available in this country. So it's right now not our purview to speak on that. One question from Dr. Gautami is, please clarify what is the PIP working pressure set versus the set PIP in VG mode. I think you can just once more answer that.
Yeah, in volume guarantee mode, the PIP is not set. Whatever we set in volume guarantee is the pressure limit. Below that limit, the ventilator will increase or decrease the PIP to deliver the set tidal volume. Usually in volume guarantee, we are not going to set the peak inspiratory pressure. Whatever we are setting is actually the limit of the peak inspiratory pressure. The ventilator actually delivers the fixed tidal volume within that limit. So, for example, if the ventilator is taking a peak inspiratory pressure of 14 to 15 centimeter of water, that is called as working pressure. But limit we would have set at 19 centimeter of water, around 3 to 5 centimeter more than the working pressure.
Just to clarify again, Dr. Gautami, since you're setting the volume and the lung compliance keeps changing, the ventilator pressures keep changing, and that is called the working pressure. Even in one respiratory cycle, it changes, or during the course of the day, it may keep changing. What you're setting is the higher end of the pressure. It's like a pop-off valve. You don't want the PIP increasing to more than that. Whereas the working pressure keeps changing, only the set tidal volume is fixed. So as Dr. Pratik had nicely pointed out in the graphic illustrations, that is what is called the working pressure. But it's a very simple thing. That is why as the child's lung compliance starts getting better and better, if you give surfactant or something, there is an automatic weaning of the PIP also. That's the working pressure which happens. So we are almost coming to the end of our presentations today here. Just a little bit word about so important is to humidify the air which we are giving. Shashi, any ideas on what should be appropriate humidification?
I think we should only use humidified air. I think appropriate humidification, ideally, it says 85 to 90%, 100% is the target, and the evidence is very, very strong, because you take away the effort needed by the baby to actually humidify it and heat the air, And that way, you're not only reducing the lung issues, but also the metabolic issues associated with using cold air. So I think even for short-term CPAP, we should only target using humidification. Now, again, you might not be able to achieve 100% humidification, because for that you need a separate circuit with a, not the circuit, the concentrator and all that. But even otherwise, whatever humidification can be provided should definitely be used. And for using in the high flow, humidified high flow, and there's again, it's a complete no-brainer, because the evidence is so well written. And using short-term low flow also, the question is again whether we should humidify it, because drying of the airways, and also drying of the airways not only increases the turbulence and all the other things, but also associated the mucosal trauma, and all that can also be prevented by humidification. Now, exact numbers wise, so my experience is that I don't know the exact what degree of humidification should we be achieving. I mean, I'm open for suggestions from
No, I absolutely agree and concur with it. Even if you are just giving simple low flow oxygen through a hood or through a nasal catheter, it should be heated and humidified. That's absolutely, it's not at all, it's indisputable. It makes the secretions better in the baby. The villus movement, the cilia, they become better in their motility. Surfactant production is increased, oxygenation is better, and the severity of lung injury is lesser. So humidification has become necessary, even if you were to be given low flow oxygen. So the olden days where you just run the oxygen through a simple flow meter is not done anymore. You do have to use a heated humidified circuit. You have either a simple heated humidified circuit without a thermoregulatory sensor, or you can have the modern nowadays, the simple servo controlled sensors are available in the circuit itself. And of course, modern technology is now able to deliver good humidification. So with this, I think all the questions are done. There's only one question, which is suggesting, can we give caffeine to mothers who are pregnant to improve their baby's preterm outcome? Is there any question, any answer to this? Any of you, please? This is from Dr. Abhimanyu Kumar. Anybody can suggest caffeine to the mother? We know of antenatal steroids, we know of magnesium sulfate. Caffeine to the mother.
I don't remember any study.
No, I'm not really sure. I'm sorry, but I think till we are very sure, I don't think we should probably suggest giving caffeine to the mother. Baby, as soon as the baby is delivered, within the first 1 hour itself, you can give a loading dose of caffeine to the baby, even when the child needs ventilation. Definitely, that is a good thing to do. So with this, probably I'll come to the conclusion. I don't think there are any more questions. It's been wonderful having Dr. Shashidhar Vishwanath and Dr. Pratik with me on the panel here. I thank Mr. Siddharth Bharadwaj from Fisher Paykel and Ms. Monica Bakshi from Fisher Paykel and many other colleagues from that company for having had this presentation, which has been probably very, very beneficial. And since it's going to be recorded for posterity on the YouTube, maybe it will set many people's a lot of people can have access to this in the long run. And probably they can pose some questions to us. If there's a need, we can answer them. Thank you so much for the opportunity. Wonderful having you both here. Thank you so much.
Thank you, sir.
I think, thank you, doctors, for your time. We really appreciate it, especially during these times when critical care is at its peak and there's so much happening. We really appreciate your time, and to the audience as well who spared their time for this very educational and beneficial session. Thank you so much, and stay safe, everyone. Have a great evening. Good night. Thank you so much.
Thank you.
Thank you. Thank you so much. Thank you.